All right, welcome. We're going to dive deep into the hyperacute stroke protocol. The decisions you make in that first hour, well, they're some of the most critical in all of medicine. We are going to walk through this, step by step, covering all the key decision points so you can act with total confidence and precision when that clock is ticking.
Okay, so let's jump right into a classic ED scenario. Your patient is wheeled in, less known well was just 90 minutes ago. You can feel the anxiety from the family, the paramedics are giving you a quick handover, and all you can hear is that ticking clock. So, what is your number one absolute first priority? Let's break down the protocol. So here's our game plan. We'll start with that controlled chaos of the first 20 minutes. Then, we'll move through the two huge treatment pathways, ischemic versus hemorrhagic. After that, we'll cover the really essential supportive care and the secondary prevention that really sets your patient up for recovery.
Look, your mission in this phase is simple, but it is absolutely non-negotiable. It's all about a rapid, focused assessment to get to the single most important diagnostic test. You've heard it a million times, time is brain. And these first few minutes, they set the pace for absolutely everything that follows.
This right here, this is your mantra. Patient arrives, you're confirming the stroke, maybe a quick fast assessment, face, arm, speech, time, and you're quantifying the deficit with the NIH stroke scale. Within 10 minutes, you need 2 large bore IVs in and a point-of-care glucose checked. You gotta rule out a mimic, like hypoglycemia. And the ultimate goal, get that patient into the CT scanner within 20 minutes of arrival. Every single action is against the clock.
Now, it is absolutely critical to understand the primary goal of this first scan. You're not actually looking for the ischemic stroke. In fact, a lot of the time, it won't even be visible on an early non-contrast CT. Your absolute priority is to rule out a hemorrhage. And why is that? Because seeing blood on that scan completely flips your entire management algorithm from let's bust this clot to we have to stop this bleed.
So the CT comes back and it shows no bleed. Great. You've just made the diagnosis of acute ischemic stroke, and the door is now officially open for reperfusion therapy. This right here is where we can truly change a patient's outcome.
This is your IV thrombolysis checklist. First, you confirm they're in that 4.5-hour window and have 0 contraindications. Next, you have to get that blood pressure down, target less than 185/110. Then, you dose the alteplase correctly. It's 0.9 milligrams per kilogram with 10% given as a bolus and the rest infused over an hour. And after the infusion, strict BP control is vital to prevent a hemorrhagic conversion. And remember, you must hold all antithrombotics for 24 hours until a follow-up scan gives you the all-clear.
Okay, here's a clinical pearl you really need to know about. Tenexteplase, or TNK, is being used more and more as an alternative to alteplase. Its massive advantage is the dosing. It's a single 0.25 milligram per kilogram bolus. That's it. This is incredibly practical, especially in what we call drip and ship situations, where you're giving the drug at a smaller hospital before you transfer the patient out for a thrombectomy.
You know, knowing when not to give thrombolysis is just as important as knowing when to give it. These right here are the hard stops. Any prior brain bleed, any active bleeding, or recent major intracranial surgery, these are absolute contraindications. You have to know these cold. There is 0 room for error here. Patient safety is everything.
Now, for some patients, the ones with a large vessel occlusion and LVO that we see on their CT angiogram, IV thrombolysis by itself just might not be enough to get the blood flowing again. We have to physically go in and get that clot. And that's where endovascular therapy or mechanical thrombectomy comes into play.
In this slide, this just brilliantly illustrates one of the biggest advances in modern stroke care. We used to be complete slaves to the clock, but now, for some patients, we can actually intervene up to 24 hours after their symptoms started. So how do we do that? Well, with advanced imaging like CT perfusion, we can see the mismatch. That's the amount of brain tissue we can still save, the penumbra, versus the tissue that's already gone, the core. If that mismatch looks favorable, then guess what? The window is still open.
So let's just quickly summarize the key things to think about for thrombectomy. It's for a confirmed LVO that's causing a significant deficit. And this is important. If the patient is eligible for IV thrombolysis, you give it. We call that bridging therapy. The IV drug starts working on the clot while you're getting the patient prepped and into the angio suite. The blood pressure targets and that 24-hour hold on antiplatelets, they're exactly the same as for IVT alone.
Okay, let's rewind. Back to that crucial moment in the CT scanner. But this time, the scan shows blood. We are now on a completely different treatment path. Our entire approach pivots 180 degrees from being prothrombotic to hemostatic.
For an intracerebral hemorrhage, your actions have to be swift and deliberate. You stop any blood thinners. You reverse their anticoagulation immediately, and you need to know your reversal agents, like PCC for warfarin. You lower the systolic blood pressure aggressively, aiming for a target around 140, to limit the hematoma from getting any bigger, and you consult neurosurgery urgently.
Honestly, this slide right here is probably your single most important reference for managing blood pressure in acute stroke. You should probably pin this to a wall somewhere. Just notice the stark differences. For an ischemic stroke where we're not intervening, we actually allow for permissive hypertension to help perfuse that at-risk brain. But if we give thrombolytics, we need tight control to prevent bleeding. And for a hemorrhage, we drop it low and fast to stop the bleed from getting worse. You have to understand the rationale behind each of these scenarios.
Okay, so once you've navigated that hyperacute phase, the clot is being busted or the bleed is finally controlled, your focus has to shift. The goal now is to protect the brain from any secondary insults and just create the absolute best environment for it to heal.
Now these measures, they are not optional extras. They are fundamental to good stroke care. Early VTE prophylaxis with compression devices is crucial. Strict glucose control is key. Hyperglycemia is literally toxic to an injured brain. You keep the patient NPO, nil by mouth, until a swallow screen is passed to prevent a really devastating aspiration pneumonia. And you have to aggressively treat any fever because it just increases the metabolic demand on a brain that's already under a ton of stress.
So the patient is stable now, they're on the stroke unit, but our work is definitely not over. The process of preventing the next stroke, well, that begins the moment the first one is diagnosed.
And here's another high-yield pearl for you. For patients who've had a minor ischemic stroke or what we call a high-risk TI, we have really strong evidence that a short, 21-day course of dual antiplatelet therapy, that's aspirin plus clopidogrel, is better than just monotherapy for preventing another one in that critical early period.
And for every single stroke survivor, these are the 4 pillars of long-term care. The right antithrombotic strategy, a high-intensity statin, strict long-term blood pressure control to below 130/80, and aggressive management of lifestyle factors. This is how we reduce the risk of another stroke and really impact our patients' long-term health.
So I'll just leave you with this question. The acute management, it's a technical challenge for sure, but the greatest victory is won in the weeks, months, and years that follow. It's all about building a partnership with your patient to get to the root causes. That right there, that is where you will make the most lasting impact. Thanks for your attention.